John, thank you so much for joining me today and being willing to interview, giving me of your precious time because I know how busy you are. But being here with Julia, I know that you just did an interview live Facebook with Julia and her surgical experience with you. And I have to tell you, being here through the whole experience and seeing the facility and the way that you are running things and the staff here, it's just been an amazing experience. And I have to tell you, being a practitioner, I work with a lot of women who are very sick with breast implant illness. And a lot of them, have explanted and are not getting better. I've exhausted a lot of my resources for supplements or therapies. And, I just have come to the conclusion that there's so many aspects of breast implant illness to heal. And being here with Julia, it made me realize that one of the biggest things that need to be talked about is total capsulectomy.
No, thank you very much. Pleasure to have you as a guest. We are very transparent, as you will see. We welcome you. We are in an operating room that we do not use. And so we want to bring you in so you can see firsthand, and you will let others know that our only interest is to help you, help the many other patients understand what the informed consent aspect of the augmentation means, so that other patients who follow us, who understand my practice, can truly comprehend that we are all patient-centered. We have no other interest, no motive except to help the patients, so that when they get their surgery done, they have had the best personal experience, they have the best surgical experience. And I will tell you, it's not only I, but my office manager, who is there from her heart and soul 24/7, like myself, my Sally at the front desk, Marlena, and the rest of the surgical team, because it takes a whole team effort. And truly, I'm blessed and honored to work with a gifted, nice people. And I am glad that you're here and you truly enjoyed it. Had you not come, you certainly would not have tasted our practice in person. And you truly have that perspective as you leave what we're all about. And why is it that what we do and what keeps us going. So this is very important, and I'm glad you're able to enjoy that experience.
Yep. Yeah, there was a sweet moment, and I have to bring it up because it almost made me, tear up when you came into the operating room on the day of Julia's surgery, and you took the blanket, a warm blanket, and you put it over her, and you put up the sides of the bed, and just were taking care of her. Well, Julia and I, we talked about it. We thought. That's just so caring.
No, thank you.
That you would take care of her like that. So thank you.
No, you're welcome. Again, from the bottom of our heart, yeah.
We just appreciate that.
Sure. Now, please ask me any question. See, in my mind, I look at it in a certain way, having talked to a lot of patients. And I've been seeing patients from 1997, talking to them, interacting from the time I was a medical student to resident, fellow, a little bit about myself, my training. I did medical school from Chicago Medical School, and then I did my general surgery residency, where I did 5 years of training. Following that, I did 2 years, during this time, I did 2 years of burns, so I'm burn certified in critical care. And then, so that's now 7 years, and then 3 years after, which is basically board certified by ASPS as a board certified plastic surgeon. So 10 years where I will tell you my entire life, day in, day out, was committed, devoted to learning not only about plastics, but about patients, other aspects, and body as a whole, and certainly the surgical techniques. Every surgeon, every professor of mine taught me something, and I learned from their efforts, from their teachings, from the conferences, and it literally, and I'm still learning. And in the sense that we're learning from each other, we're learning from Dr. Henry Dykman, we're learning from the many other plastic surgeons. Look, I mentioned the study from Dr. Metzinger, who did 200 of his patients with total capsulectomy, and this ongoing process. We have learned, and sometimes the best way to learn is to learn from the mistakes. When I use the mistakes of the 1992 ban and how they were reintroduced, and now history is repeating itself. So it's a pleasure to be here with you, and it's a very good platform for you to ask me any questions, because you can now, when you talk to your patients, you can highlight what are their concerns, what you find are, I use the word, the deficiencies in their thought process, or how the other doctors are thinking, and what we know now in 2024. So please ask me, and hopefully I will be able to discuss and share my thoughts. I always say there are many things I know, and there are a whole lot of things that I do not know and have no clue about. And so if I do not know, I'll be the first person to mention.
Yeah, I appreciate that.
You're
I appreciate
welcome.
your openness and honesty. So if you could just explain a little bit about total capsulectomy and how women will know, because they're telling me, oh yeah, the capsules are out, but they're not. They're just the thin capsules are surrounding the implant. And when you explain to Julie and I that you actually have to go beyond the implant to get all of the capsules out, correct?
That is correct. So very good point. If I may mention, there are other surgeons before me who have coined and mentioned and discussed heavily the words en bloc or total capsulectomy, like Dr. Chun from California, Dr. Feng from Ohio. These are veteran surgeons practicing for decades and doing the explants in the manner that they do. Their technique, interestingly, is different than mine, where they're exclusively using drains in all patients, or they're doing that lift around, and again, their own standardization as far as how they do it, their specific way. From my experience, and to answer your question, I know from my experience and from the pathology, because I find the most important piece of information that gives me feedback is the pathology. I noticed where once the capsule is removed, which is what is the en bloc, that the tissue around where you have fat necrosis, chronic inflammation in that tissue around, so it's not only just the capsule, but the fatty tissue around, histocytic reaction, there is, and histology has showed that tissue around the capsule, it can have in it silica. Remember, it's leaching out of the intact silicone implant, intact saline implants. So it is not only the capsule per se, but the tissue around that also needs to be removed. That looks dusky, suspicious. It has that gray, dusky yellow appearance of fat. All of that needs to be removed, and the pathology has shown fat necrosis, histocytic reaction, chronic inflammation, giant cell reaction, refractile material consistent with implant particles, for example, non-polarizable. So that has shown to me, grossly looking at it, I can see it's abnormal. So when I do dissect the capsule out and there's tissue around that looks abnormal, and this is where that precision, that care comes in, so that all of that tissue is removed such that once the surgery is done, I have the peace of mind that there is nothing inflamed. I don't want to go back and say, I wish I had removed that, because now,
right, you can see it.
yeah, and there are times where you're not sure. You're sitting on the fence, should I remove or not? I remove it, because you always want to err on the side of removal, because you don't want the patient to be hurting potentially from what is that breast implant illness, till proven otherwise.
Right. Yeah, it's difficult because that makes sense to me, right? It just makes sense, and so unfortunately, BII is not recognized as a medical diagnosis, right?
That is correct. Yeah, we don't have an ICD-10, yes.
And or ICD-10, we don't have these codes, and there's no protocols really for capsules, right? There's not a standard of protocol.
That is correct. So the general consensus amongst the plastic surgeons is this: leave the capsule alone. It does no harm, which is wrong. The capsules are benign. Removal is very problematic. It can get bloody. There is risk for pneumothorax, that is air within the lung. And it's a very tedious operation and not required and not worth it, and should not be practiced. Now, having said this, in the medical literature and scientific literature and the plastic surgery teachings, and this is what I was taught in my training, if a patient has BIALCL or the lymphoma, it is required for that whole capsule to be removed, no matter what. Because if the capsule is left behind, the cancer is left behind. So we have to practice this not only from the BIALCL, which is the breast implant associated anaplastic large cell lymphoma, which is very rare of rare, which is very rare, but also more importantly from the perspective of the breast implant illness symptoms, because we know these two situations where the capsule was left behind, the patient did not improve. The patient continues to feel the hurt as if she had her implants already inside, they were never removed. And the patient continues to linger on with the many signs and symptoms of breast implant illness. And we have a lot of patients in this category. Some of them do not know that this 70% improvement could have been 100% had the whole capsule been removed. Now, do I know this? No. How many patients do I take care of? Do I guarantee, even to Julia, that you're 100% going to get better? I said, I do not know what I'm going to find. I said, I have never done a case for Julia like Julia's where the patient already has undergone a supposed en bloc and a residual capsulectomy total, and now I'm the third person and she's going to come out here and I'm going to break her heart and that I'm not going to be able to find anything. So this is where I don't guarantee, but I guarantee that I'm going to go out of my way to removing the whole capsule, because I know the two situations where the patients have improved and the whole capsule has been removed. And Julia's story is exactly very real. And number two, we know from the pathology report that that's the inflamed bad tissue, chronic inflammation, histocytic reaction. So that is the proof in the pudding, if you will.
Well, and there's a lot of women who don't trust their intuition, right? They know something's wrong, but they believe, oh no, my capsule was removed, and it's like, what do you tell them when they're suffering from BII and they have all these symptoms? They've tried detoxing, they've tried, IV therapies, they've done all of these modalities, but they're not getting better, because even Julia had, the ultrasound, and all of the doctors were telling her, your capsules are removed. There's nothing.
See, no, this is where if someone says, give me the proof that the whole capsule was removed, I will say I just want one evidence, which is a video of the chest wall showing the rib, where the cartilage of that the periosteum, perichondrium has been removed, the fascia of the intercostal muscle, that's the muscle in between the two ribs, that fascia has been removed, the fascia of the pectoralis minor, fascia of the serratus anterior muscle, and inferiorly below, that lower part of the pectoralis major fascia has been removed. If I can see that, then I can attest to the fact that that whole capsule was removed. And this is what I mentioned earlier. Those patients who go to a doctor who are not augmenting, that authenticates the fact that they're going to do it right wholeheartedly, that they have the length of time it takes to remove on average, a average implant 350, 400 cc's is 4 hours for me. That is plus minus. The pictures, high definition pictures, videos, the surgeon has made an incision that's long enough where the diameter of the implant dictates the length of the incision. And number 5, that the surgeon who's not augmenting will genuinely do the explant right with removal of the capsule, and that surgeon has a track record of patients who will attest and swear to the fact that he's removing the whole capsule. Because after some time, the word will get around that he's leaving or she's leaving the capsules. And we know those patients where the capsules were left behind, those patients do not bounce back completely or do not bounce back.
And that makes sense to me, because I've done, mold detoxification. I've done bacteria. I had a bacterial infection. My surgeon, when I explanted, I told her take everything. Mine was over the muscle. So she just took everything, basically gave me a mastectomy, did a biopsy, and found a C. acnes bacterial infection in the capsule. So, having that is so important, right? Having the biopsy done for women is an additional thing.
Right, yeah.
Right?
So what I do for my patients is I do aerobic, anaerobic, and fungal cultures. And in these cultures, I find from my practice, 10-15% of the time, there is a biofilm colonization by bacteria, the Corneobacterium acnes that basically lives in harmony with the body, where the biofilm forms if you look at the chest, the patient has no active infection. But this is precisely, I give the antibiotics right before surgery and for a 7-day course, so that that bacterium does not have the ability to grow or potentially become a problem. Remember, the treatment of choice is what? Removal of the implant and certainly removal of the capsule, so you have only good, healthy, viable tissue. And then I also send cultures for fungus. And this is where we have, after the surgery, that confirmation, that mental satisfaction that there was no fungal culture. Last Friday, 6 days ago, I got the culture report back on a case that I had done, and it growed mold. I referred the patient to infectious disease, and now the patient is going to get seen just so that she gets the definitive care from the infectious disease doctor.
Yeah, because there, I mean, depending upon having mold or bacteria or, even parasites, anything that could potentially be in the body, a pathogen, right, needs different treatments. There's different treatments, so having those specific tests is really important. Right.
Yep. So now I will mention, out of 100 cases, 15% or 15 patients will have that bacteria that will be present. And that is not an artifact, but it's a known phenomenon, because not only I, but other plastic surgeons have reported it. Now, fungus infection is very rare of rare. So this is not where fungus lives, but it has been shown, because the cultures have come back, and these are real cultures. These are not artifacts. Now, obviously, when you take the swab and then you grow it on a petri dish, and the fungal cultures take 4 to 6 weeks, and they have to speciate the fungus, it is, remember, very rare of rare. This is not typically where fungus grows, but fungus will grow even around hip implants, for example. If the patient is a diabetic, for example, there is a tendency for Candida. But this is where a thorough, complete, comprehensive microbiological workup, pathology workup is done, so that the patients know what was present and what was not present. So the patient gets the best post-operative care.
Yeah, I love that. And then you also send off pathology reports for heavy metals or silica, or what else do you send it off for?
So the capsules are sent to pathology, or any abnormal masses I send to the pathologist at the hospital. And they look for any abnormal pathology that includes breast cancer, chronic inflammation cells, BIALCL with the CD30 analysis, anything that they find abnormal. I do not check for heavy metals. Remember, that's an industrial lab.
Right. So I'm like, what else is there? If I'm not finding the heavy metals, not everybody has the mycotoxins, not everybody has, there's a percentage that have the bacterial infections, because I had one.
Yeah, a percentage, a very small, 10-15%.
Very small, so I'm like, what else? What else could there be? And then you have to, the Asia reaction, right?
Yes.
The autoimmune reaction, so I'm like, there has to be something there. Because my capsules, because of the bacterial infection, now I have spondylitis. So I have this chronic spondylitis from the bacterial infection that was there for 14 years. Mm-hmm. And it's hard because not enough focus is on the autoimmune reaction to the capsules, to the implants.
To the implants, right, yeah.
And because the capsules are not being removed, and so I think women are having just an Asia response. They're having that autoimmune.
So the whole breast implant illness is where the whole body's immune system reacts to the implants, which are considered foreign, and now there is an immune response where the body essentially starts responding to this chronic inflammation, and then the rest of the systems go haywire. Especially now, we know from the lymph node biopsies that have been done of the patients who have intact saline, intact silicone, and certainly ruptured implants, where they have found on imaging MRI, not only biopsies, silicone within the lymph nodes. We have found within the tissues around nerves. These are studies that have been done on cadavers who had autopsies that were done on patients who had ruptured implants, and hard evidence between electron microscopy and energy dispersive X-rays that convincingly proved that this was the silica in and around these tissues. And so we know this exists, and this is where the body is reacting to this poison. what you mentioned is, if you look at the list of chemicals that compose or make up an implant, you will see all metals like platinum, amongst the many others, that once it disintegrates, starts reacting, the body reacts to these chemicals. We also know these many subset of patients who got silica injections in their buttock or enhancement of their arms, for example, biceps, done unfortunately in a lot of places like Florida and New York, where they have this reaction again, where they have these, quote, warm type feelings where their silica starts migrating downward. And this is essentially the point that the silica itself is not healthy. It's reactive, and the body reacts to it in what you mentioned, in the immune way. Yeah, it's not inert. It's not inert.
The
Yeah.
molecular weight. What is your specialty? I know that you had mentioned that you had done something in
My undergraduate major was biochemistry.
Oh,
So
perfect.
basically, in the labs that I worked, I have worked with amino acids, ribosomes, for example, molecular biology. And this is where you understand in biochemistry the parts per million, parts per billion, of what is in the water, for example. We're looking at small masses of chemicals using, for example, mass spectroscopy or NMR studies, nuclear magnetic resonance imaging, or MRI, if you will, that looks at different compositions of chemicals, how they affect us on daily life. And this is part of my training as an undergraduate. And any biochemist or molecular biologist will tell you it's a very popular field of study, especially for those students who want to go into medicine. Because you're not only looking at the biology, but also the chemistry and how they integrate together.
That's very impressive.
Yes.
We need somebody like you, like this, just because silicone is, dimethylsiloxane is very low. Like the molecular weight is really, really low, which makes it more susceptible to migrating in the body. And there's nobody talking about that, or the catalysts, or the manufacturing process of breast implants, and how it can get in, once it's implanted, it can spread to the body, it spreads to the tissues, right? And especially in the capsule, which is why I think it's so important to remove that capsule completely.
Right, and it is the take-home message of any breast implant illness discussion that the entire implant capsule and that inflamed tissue around must be removed in the en bloc fashion, where there is no break in the capsule, or as 100% total capsulectomy with all inflamed tissue removed, and then it being tested and the microbiology being done and the pathology being done, so that the patient has that peace of mind that all of it was removed. Now, as you will see, you have a lot of inflammation present on the chest where the implants are. Now you see some in lymph nodes. I leave those alone. I do not want to disrupt that. It will be, I use the word malpractice to disrupt that lymph node basin, because then the patient can get lymphedema. The goal is to remove that burden of silica so that the patient has the best chance of recovery. And I say the best detox is where the surgeon goes and removes the entire implant capsule and all inflamed tissue, so that you have the peace of mind that all of it was removed.
I was impressed when you went all the way down to the bone.
Yes.
Right? I could see the ribs. And I don't see any surgeon posting videos about going all the way down to the ribs, because you're right, it's there. That's where the capsule
when you see those videos, Julia's videos, you will see how intense the surgery is, how involved, it's very tedious, it's time consuming. And yes, the plastic surgeons and the societies have mentioned that it is, I use the word risky because these are the terms that they have used, but this is the surgery I say from my practice is required for the patient to recover fully. We do not want an incomplete surgery where the implant is removed and an attempt to remove what looks like a potentially bad. No matter how thin the capsule, it must be removed. We have seen many times from the many Facebook Lives, the capsule is so saran wrap thin that you can actually read the ruler and the lines and the writing through it. But that is the problem, the root cause of the problem.
Yeah, and then women think that their capsules are removed. When I saw Julia's video, and mean, literally, we were sitting there on the bed together watching the video, and you had pulled out this huge piece of capsule and tissue. I mean, very huge. Julia basically dropped her phone, and we were like, oh, both of us, oh my gosh, because we were so shocked after she had already had, you know, these surgeries. We didn't expect that much to come, for you to get that much.
Mm-hmm.
And I just want women to know that a thin little capsule, it's just not good enough.
And as you will see, it was that thin capsule, but that inflamed tissue around. So you can see all of that tissue did not look healthy. And there were clearly, as you will see, and I spread it out, you could see that glossy gray, some white, some dark purple matter, unhealthy tissue. And you know from your heart that's the culprit. Now, we will follow Julia 1 month out, 6 months out, a year out, and she herself will recognize the improvements. Her family will recognize, her joints will talk, her eyes will talk, her GI will talk, individually, collectively, and she has nothing to gain from all of this in the future. There is nothing except for her good health, and that she will be another attestation to the fact that implants caused her harm, and that partial capsule removal from the first attempt, second attempt were inadequate, and that it is the complete total capsulectomy which is key. You do not want to be that one patient who goes in and gets an incomplete surgery and now has to undergo, from my experience and expertise, another surgery where you now have to get the job done. And now the financial commitment, physical commitment, the commitment of leaving the family, the job, and the recovery, it is much more involved removing the implant capsule, and in this case the residual capsule, than basically removing it in an incomplete way. So I hear and I see the many patients, for example, oh, I went to this surgeon who charged only this much, or this much for a lift and an explant, and this person is the expert. I say we have to compare apples and apples and not apples and oranges. We have to compare the two surgeries. These are not the same. If you go get a certain product X, this is not the same product X that the other surgeon is giving. These are two different experiences, two different thought processes by the surgeon, two different mentalities, two different surgical techniques, two different intraoperative techniques. This is where, when you see that video where that capsule is coming out, that is priceless. That speaks volumes. I say to all my colleagues, this is a surgery I find from my experience is being shown, has been shown. And if any of the surgeons, you will see they will post total capsulectomy or en bloc in their many web pages, that 5 years ago, 3 years ago, 2 years ago, even a year ago, there were not that many. And I will say this momentum by the ladies, for the ladies, educational talks like this, the medical plastic surgery community, and more importantly the patients, are coming to realize that that is the surgery that is, I use the word curative, that is going to help, and that those patients who have had implants removed alone, leaving the capsules behind, do not improve, and sometimes they do not know any better because they do not realize that 50% improvement was just the 50% and not the 100% improvement. They think that it is their postmenopausal status, or it was their diabetes, or this is just the stresses of life. The many ladies who have explanted right, and you will hear directly from them the benefits of explantation. If it prevents one person from getting an implant, we have done good. If another person explants successfully in the manner that I described, that I feel that needs to be done, that research and clinical evidence is pointing towards, and what the patients are pointing towards, then we have done good. And this is what we are doing. We're raising awareness in a very professional way. We're just telling the patients, if you're hurting, these are the answers that you have available, so there is relief. There are millions of ladies out there who have implants who do not know that implants are causing them the harm and hurt, and that there is a relief out there such that when you do it in the right way, you can have a very reasonable post-operative course, and where time is going to prove to them that they did the right move. Every day, I talk to my patients, and I'm very, as you can see, understand my patients. I am excited to talk to my patients, and I'm happy, and it gives me that positive feedback so that I can offer the same to the next patient from the bottom of my heart. Yep.
We feel it.
No, thank you.
Julia,
Thank you.
we feel it.
No, thank you. Thank you very much. Appreciate it.
Hello, this is Cecily Henderson. I would just like to thank Dr. Khan and Julia for making this interview possible. I'd also like to thank Dr. Khan's staff and for all of those who are watching this interview today. We need more awareness of this devastating illness. We are desperately trying to reach people who do not realize or understand the ramifications of breast implants. I am looking for those who would like to do interviews and tell their personal story about breast implant illness. My husband and I are 100% funding these interviews and videos right out of our pocket because we believe in this cause. The more research and the more awareness we spread, the more people and more lives we will touch. If you would like to participate and share your story, please contact me at biihopeforhealing@gmail.com. Thank you so much for your support.